team lead. Ideally, in normal situations before I think I came to simulation, I wouldn't be in a position to be a team leader when leading a case or just playing along as a team member. What are my roles? What am I supposed to do? But with the introduction of simulation, that has really, really helped a lot. I have gained more confidence, I've gained more courage, learning from these scenarios that I can like go back and just do these things on live patients, and I'm like, yes, I actually did this. Like, yeah, it's like really an amazing experience. I'll be at the Simulation Symposium. If you want to learn more, you should come on the 16th of this month.
My name is Makanga Silva Evans. I'm a fourth-year medical student at Mbarara University of Science and Technology. I've been exposed to simulation training for the past 2 years during my clinical years. And with this training, we're really exposed to real-life scenarios that we meet on ward and maybe elsewhere. What this helps us is that it augments the training we receive in class and on wards, such that in a way that when we actually meet real-life patients, we are ready. Personally, it has helped me. I am more confident and more courageous when I'm approaching real-life scenarios. And because of that, I encourage everyone, and we have been talking to the university administration, to expose this same training to other people of other courses or maybe earlier years who may benefit from it. If you want to know more about simulation training, come for the Sim for Life Symposium on 16th of this month. I will be there too.
My name is Dr. Albert Muhumza, and I work here at the Simulation Center in Mbarara University, and I work with a vibrant team to grow the simulation method in Uganda, Tanzania, and Nigeria. And what we're doing in Mbarara University is that we're extending this methodology to the postgraduates so that we can address the limited number of people that...
So you're welcome for this session, today's session. In today's session, we are going to have Wycliffe as our patient and Brenda as our caretaker. So in case you need anything to know anything from the patient, Brenda will provide the information, and this is the patient's file. We have also prepared for you equipment that we feel you will need during the session. We have vital observation equipment for you here, the BP machines and glucometer. We have a thermometer, so in case you want to assess the patient, the equipments are here together with the pulse oximeter. We have vacuum here of different color tops, and we are missing a red top container, but you can assume that this is a red top vacuum, and you verbalize it so that we can know. And then we have these are nozzle prongs. You can see them, they are here. This is a patella hammer if you need to use it. This here. We have cannulas of different gauges. If you want to give fluids to the patient, you can choose from here, but you want to maintain this environment as safe as possible. So once you open a cannula, please endeavor to dispose of the trocar into the safety box to avoid needle prick injuries. The same applies to the giving sets. Once you open the giving set, endeavor to dispose of this needle into the safety box. We have medication, some in powder form. For the medication which is in powder form, you should not mix these drugs, but you're just going to tell us how much water for injection you need to mix the drug and how much you're going to give to the patient. Likewise, the medication which is in ampoules, the ampoules should not be broken. So if you want to give medication which is in ampoules, don't break them, but you're just going to tell us how much medication you're going to give. So for the IV fluids, we have prepared different IV fluids here, depending on what you want to give to the patient. Here we have different steps you have to from the catheter, down. So in case you need something and you don't find it here, you speak up, I'll either tell you where it is. So if you want to give fluid to the patient, we have prepared for you everything you feel that you're going to use. Request you not to reconstitute this powdered medication. If you want to use it, you pick it and tell me how much of the water for injection you wish to add and how much of the drug you want to.
Hi, my name is Nawete Bosevaduka. I'm a fourth-year medical student. I have been in simulation, I think, for 2 years now. It has been a wonderful experience because we get to have these scenarios where we just use mannequins instead of real-life patients.
So you're going to put the cannula from the cannulas, use them the way they are to avoid injury. But in case you open one with a skillet, you dispose of the skillet first and use it without it. If you want to, and then after cleaning the area, you're going to insert the cannula where you want it to be, and then you fasten it in place with the strapping. So when it comes to giving the fluid, so assume that you're using that particular fluid. You can hang the bottle up of the fluid of your choice that you want to put up, and then we are not going to put this giving set onto the cannula that we have put because it's not in the vein. We are going to run this bottle onto this collecting pot here, and then you let the fluids run according to the rate that you want it to flow. You connect here, and then you adjust it to the flow rate that you want it to run. It's about to collect the fluid down. So we have the waste bin here. Yeah, so then we have the yellow bin here. In case you have any waste that you want to dispose of, if you have this yellow bin, you can dispose of the waste there. And then we have these books here, which are the reference materials. In case you want to read about something, confirm the dose, or maybe a management of a certain case, the books are here for you, you can read. And then the telephone is here. If you want to call any department or any person in the hospital, please you can use this telephone to call. I'll be the voice on the other end to give you feedback. And I think so. What we are going to have here is the case scenario. So, do we have any question? I'll read for you the scenario before you start. Yes, and what I expect of you is to manage the way you manage in the hospital. Yes. Yes. And the other is going to be the patient attendant. Give you any information about the patient. This is the patient file. Feel free to use it.
Can I ask? Yes. Our patients, are we free to examine the patients?
Yes, we are free to examine the patient. We are free to examine the patient, and on examination, I'll tell you the findings. Yes.
I request you to.
Any other question?
Just calling someone, but you tell me the person you wish to call, and I will answer on behalf of that person. Yes, in case you want to consult or inquire anything from any other person, like in the clinical setting.
I'm inquiring about this. Your background is not medical. Oh.
That's why I'm well, so I'm into that. Trying to be more specific. I don't want to do wrong things here. But I can observe other things I can do them.
Yes, you have a team. They are doctors.
Yes.
Yeah, so you will help where you can. You assist them. Yeah, you're going to be working as a team. Yes. Okay, if there are no other questions, I'll give you 1 minute to step out of the screen a bit and form your team. Yes.
Are we good?
Yes, thank you.
So if we are okay, we can just step aside there, we form our team, and then we come back. I'm going to call you back after 1 minute. Just step aside and form a team. Thank you. Okay.
Because she's not alone. So the leader needs to be very vigilant and directing people what to do. So
Okay.
you can let us.
That's a general consensus.
Yes.
Okay. So, all right. So, okay. I'll take the lead then. Then we'll find out what kind of what scenario, what kind of problem the patient has. Then we see how we can
So the team. Okay.
Vitals. Right? If you need IV, please.
But you need to call us.
Yes.
You need to call. It's important you know our names so that you can address us by name. Since
Yes.
Let's just mention our names. Mary is easier.
Mary, Mildred,
those.
Bachelet.
Henry.
Henry,
Bachelet.
Immaculate.
Yes.
Ahmed.
So Annette is going to be our runner. We want this. She can help us.
Mildred. Give
Juice.
chemistry.
Education, history, examination, vitals.
Anybody can do it. It's him. It's for him to do.
So any other thing?
What is construction?
We are good to go.
Oh, well, when we are ready, we can wait. Or she'll call us? Or,
Since he's taking history, he will document.
Please come in, we need your help here.
Okay.
Before
before you is a 45-year-old male, HIV negative, a referral from Uganda Hospital who has been admitted. Our round has just been
So we
done.
have a 45-year-old male who is HIV negative, and a referral from Uganda Hospital was admitted with confirmatory diagnosis of acute bacterial meningitis. A ward round has been done, and the senior health officer has prescribed HIV ceftriaxone. The SHO has stepped outside but is available on phone. Please help the patient.
Okay. Please can you take some further history?
My father, it seems to be worsening.
Okay, good morning.
Good morning.
My name is Tusi Deus.
Yes.
I'm a nurse here. I'm assigned to take history. So you ask you some questions, you'll be able to tell me how the patient is. Okay? What is the name of the patient?
It's called Kakuru.
Kakuru?
Yes.
Kakuru Rook. How old is he?
45.
45?
Yes.
Okay. Where
Can't you maybe start by giving like any medication or something
Okay,
else?
there is another group that is going to give medication. For me, I'm going to take quick history, then another group is coming to give medication. Okay. How is he presenting? What is the complaint?
We came in when he was having a fever.
A fever?
Yes.
For how long?
3 days.
3 days. What else?
And headache.
And headache. Okay.
Kakuru. Good morning, Mr. Kakuru. He doesn't talk. He doesn't talk. Yes. Okay. I'm going to take
So this
his
fever,
assessment.
this fever, how long has taken? 3 days.
Yes, 3 days.
Okay. The headache?
3 days.
The headache 3 days. Has he ever been admitted?
No, this is a first time.
This is the first time admission being admitted.
Check the temperature.
Do you know her cell status?
What do you mean?
I want to insert an
This
IV.
patient, was this patient tested with HIV?
Yes.
Yes, how will you know what is this status? It's negative.
You take the patient's temperature, and it is 38.1 degrees Celsius.
38.1.
Yes. And then the pulse rate
Has he
is
been complaining of abdominal pain?
90 beats per minute.
Okay. Has he lost consciousness? So you can hear? Okay.
Doctor, what are you going to give my father?
The oxygen circulation is 90.
What is this that you're doing?
I'm setting a line for your father.
I'm assessing the respiratory rate.
Okay, please go
It's
ahead.
for IV fluid. Yes. IV line set.
Patient is breathing at 24 breaths per minute.
Is he moderate?
Yes.
Can you just put some oxygen? Mary, sorry.
Pass me the stethoscope, please.
Stethoscope is here.
Thank you. So,
Any more information on the history?
Okay. This is a 45-year-old man who is HIV negative. And he came complaining of fever and headache for 3 days.
Yeah.
He's from Uganda,
Patient's BP,
but
it is
has
110/80.
no history of loss of consciousness.
Dr. I'm worried it doesn't seem
no
to be
comments?
improving at all. I'm worried it's not improving.
Okay, don't worry.
The blood pressure is 110/80.
110/80.
Yes.
Okay. All right. I think we should
Does he smoke?
check the random blood sugar.
Does he take
You
alcohol?
retake the SOP, and it is 97.
Okay. May I have the glucometer machine?
So the SOP is 97, so I think we may not put the oxygen now.
Okay.
Yes.
Okay. Can we check the running motion? You can still check.
Can we do some maybe lab investigations?
Doctor, what's going on? Are there any findings yet?
We're trying to check your patient and see what is the problem with the patient.
But he's getting weaker and weaker.
Yes.
Doctor,
Yes.
according from the history I'm taking, this patient is a 40-year-old male, HIV negative, complaining of fever and headache, and does not smoke nor take alcohol, no history of any operation. Now I'm thinking we might be dealing with bacterial meningitis.
Okay.
So we need
All
to
right.
do many investigations.
Okay, fine. Can we just set normal saline for him for now?
Okay.
Yes, Mary.
Yes, please.
Set normal saline for him.
The patient looks to be weak and weaker.
So this patient,
Setting.
this student has communicated with the team leader. They are going to find out to do many investigations. We shall find out the root cause.
How long is it going to take?
No, it
He's
is going to
getting
be
weaker
short.
and weaker.
It's going to be short. We are stabilizing him. Then we do many investigations and confirm the diagnosis. After confirming the diagnosis, then we shall give him the best treatment and see if
Take
so
some
don't
blood
worry.
for full blood counts and electrolytes.
If you have any questions, you can ask. Okay.
The patient was having
HIV
negative
headache and fever.
headache and fever.
So an assessment we need to do reflex.
Thank you.
Okay. Then maybe Mildred can.
You could assess the reflexes, the cannings, because we are suspecting bacterial meningitis.
What about doing a CSF for?
Yeah, taking the CSF.
Yeah, I think we need to also get the CSF.
Is he responding to voice?
Yes. No.
Okay.
We're sending in some blood for
Is he responding
Patient
to pain?
responds to pain.
Okay. Patient responding to pain. The eye opening, is it spontaneous or in response to voice?
The eyes are closed.
Okay. Responding to voice. Hello?
The eyes are still closed. Patient opens eyes on pain. Yes.
So I'm sending this to the lab. Take some CSF. Yeah.
Taking some CSF.
Don't we need to give some antibiotic to the patient? Some antibiotic?
Yeah, okay. He has started on ceftriaxone. Yes.
Ceftriaxone?
He has had the first dose of antibiotics, you said.
Any response?
He has had the first dose of ceftriaxone. You said you've had the first dose of ceftriaxone.
The patient, the file from the SHO is now back. The file from the SHO. Yes.
The canning sign.
Canning sign is positive.
Okay.
Our patient looks weaker.
Doctor, I think whatever you're doing is taking long. My patient is getting weaker and weaker.
Okay, so canning sign positive. 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 You can also do a Bradisky.
Okay. Due for his next dose of antibiotic.
You are doing a Bradisky sign.
There is rigidity.
Okay. So I think group members.
What are you going to give him?
I'm giving him ceftriaxone.
My father is allergic to ceftriaxone. You cannot give it to him.
Okay. So what do we do?
We can move on. We can give him. We can try him on augmenting.
The CSF microscopy culture system. Call the lab if it's ready.
Can we take?
Okay, so yes,
Did we take blood for culture?
Yes, we did.
Okay.
So
And we also cultured the CSF.
you said augmented?
Augmenting.
Which dose?
Give him 1 gram.
What gram augmented?
So I'm just assuming
The SHO is calling.
what is this?
The SHO is calling.
Read well.
Paracetamol.
Hello.
Clocks us.
Am I talking to the doctor on medical ward?
This is the nurse on medical ward.
Okay.
Yeah.
I'm Dr. Okello. There is a patient I reviewed on ward and I prescribed ceftriaxone. Have you already given the medication to my patient?
We almost leaving and the caretaker reported the patient is hypertensive to ceftriaxone. So
Please don't mind the caretaker. All my patients have been using ceftriaxone and to get good results. Can you please go ahead and give the ceftriaxone to my patient?
Well.
Okay, thank you for the information. Let me pause the tape.
Pardon? Okay.
So the doctor says that we disregard the caretaker's report that the patient is hypertensive to ceftriaxone. So he says we go on to give the ceftriaxone.
Well, but the relative said the patient is allergic. So I don't think we should do that. We should go ahead. We should look for alternatives. Let's give augmentin.
Okay.
So I'm going to give augmentin, another antibiotic, okay? Yeah.
Other medications?
Yes, paracetamol. Can you give 1 gram?
Okay. Oral?
No, IV. We're still waiting for results of full blood counts.
The results for CBC are here and the one for culture will be ready after 2 days.
This is another medication. It is called Panadol. It helps to Panadol. It is going to help to reduce the fever.
Thank you.
So we can give a
Doctor, how is my father doing?
So maybe.
I think we need to reassess the patient.
So basing on the history taking and the investigation.
I think we need to reassess the patient.
Yes, please.
Yes.
Okay.
Yes,
Okay, team. Basing.
Thank you so much, team. We are going to stop here. Thank you so much. And we are going to sit here.
Sorry.
Data has prepared another debriefing room.
Okay.
Is that still next to the
Yeah, because this room
We can go to the big hall.
Where's the first result?
end of the scenario. Thank you. Time up. Let's have a seat there for the
Thank you. Thank you, members, for active participation.
Welcome back from the scenario. Nicholas, how did it feel for you?
Well, it was intensive, but the environment was tense.
Okay.
But it felt like it felt a little tense.
Yeah, thank you for sharing your feelings. Would you like to share with us?
Thank vaccination about the institution. So who are you thinking of, the in charge or different level for the institution?
Can I say first institution? But also at times when the invitation comes from the SDH, says I want to raise workers.
Yeah. So now you can do the rest of the structure of the team. You can do that. Okay.
There are 4 P's.
There are 4 P's.
The supervisory.
And then you put the
in charge of the administration. You know, you have the supervisory, the ministry, then the
So what happens is that there you have a provider. The people in question would be you can write in, always go to training. You never get to go to training. Do you need an expo or just? That would be perfect.
That would be perfect, yes.
That's what it comes. So you do healthcare providers. So those are the main categories you shall look at in the writing. In writing
one were attended,
so for example, this one explore. So you got 5. Anybody else? I'm just moving you around. So let's, for example, trainer, go with what the training. Let's start a slower with the procedure, for example. So when we talk about procedure, we want you to imagine what happened from first until the end of the 2 weeks where they are supposed to get their vaccination. Training for health workers that for example, if a baby is born at birth, so they are supposed to receive their vaccination never gets to go. Within like the first in the second hour, because the vaccine should be on the way, should deliver, or in the second hour receive the vaccine.
So we have about 5 people on team.
So if you look at how your procedure leaflet. It was supposed to be that leaflet that came in. Where do we find that in the procedure?
Maybe we choose
the mother is choosing the other two. It is part of the procedure because the procedure is supposed to be that they should deliver in the first. So, home deliveries under procedure, but we have seen that people contributions to that.
This training. So what about this is going to deliver to training is always but also some aim is to ensure that once the plan is happening, we want this advantage so and I would think we can have that as our team for now, and we can always come back. Go to the next. So this is
all of us to know each other in what one can do best in that scenario to avoid this because there's no I'm going to handle this. I've taken the history and what the client is supposed to do. That's what I observed.
Okay, you have shared with me your ideas and suggestions and observations, but I still don't get
what
how you
me
felt.
as a person.
Yes, how did you feel?
As a feeling is that one, everyone was concerned. You get it? That is outside external.
Okay.
We were concerned that the patient should be safe in the condition. That is my feeling, which was okay.
Okay.
Still,
thank you for sharing your thank you for sharing your feelings. Sharon, how did you feel?
I felt scared. The room was so tense. There was too much. The attendant was so scared. Was more scared to the extent, I don't know. The attendant was making the other doctors feel like as if they were not doing their job. Yes. And what I liked about the doctor did a lot of work on the patient. She was very swift and she knew what she was doing at the right time. Yeah.
Okay. Thank you for sharing your feelings. It is normal to feel scared in an emergency situation. You could feel scared, and the reaction of the patient can even make you feel scared, even you as a doctor. However, as we go on to discuss, we shall talk about how to deal with such attendants in a situation like this. Professor Martha, how did you feel?
A bit uncomfortable because medicine is not what I've done in a very long time, so I know what am I going to do here. So, because I was out of my comfort zone.
Yes, it is normal to feel uncomfortable when you're faced with an emergency situation that you're not, of a condition that you're not familiar with, or maybe patient out of your specialty, you could feel uncomfortable. Yes. However, we shall discuss more and see what we would have done for this to help this patient out, in spite of not being within our specialties or not being comfortable with the condition of the patient. Thank you. Can you remind me again?
Grace?
Grace.
Yes. At the beginning, I felt like scared. Then when the team was cooperating, I felt good at the end of it.
Well, that's good. Yeah, it is normal to feel scared at first when you have an emergency. However, if you have a team that you're working with and they are cooperating and well coordinated, you feel comfortable just the same way you felt. Esther,
Yes.
how did it feel?
Well, for me, I think I've been in public health all the while, so having to manage a patient, of course, I was just wondering in my head. I was very uncomfortable too, but I was sure that somehow, so in my mind, I'm just thinking, what could it be and what would be my role in this particular thing that I can do effectively. So that was the confusion in my head. So when they started giving the history, but somehow I think I heard that it was HIV positive. Negative. So I think I got the wrong thing. So I was going to, and when they assigned the role for me to take the history, my mind was going towards the direction until the patient relations said no, that wasn't it. So, but with the history that we had, later on, I thought, okay, so what do I do? But I like the fact that the team was a bit organized from the beginning on what to do. And I think for Samaka, she just noticed that, okay, I will fit more, my strength will be on counseling. So she just said, okay, you counsel the patient. At that point, I felt comfortable, like she has identified my strength to say, you do this. So.
All right, thank you for sharing your feeling. Yes, you could find yourself in a team where you have to attend to an emergency and you're not sure whether you'll be able to help much, considering maybe your experience. However, like you say, Professor Maka was able to identify your strength and assigned you a role that you could be comfortable with. So it is important for the team leader to be able to identify the different team members' strengths. So, in a couple of words or sentences, what do you think the case was about, the scenario was about?
Okay. In this case, I think we were dealing with the female negatives.
Okay. Why?
When the physical examination, there was symptoms of death, then test was positive, and then another thing, and then we did the lung function. And also when the CBC came out, there was raised neutrophils. So we think
Okay, I had you say turning sign was positive. Was it that?
We read from the history, from the internal, from the notes.
Not from the notes, but when we were reviewing the patient, we did it and we said it was positive.
Maybe we can say that the facility doesn't have maybe the right infrastructure for some of this. There is no CME room, they don't have a projector, they don't have training materials. Or we would say the facility is too far away from the so we need to feel like that is something we need to ask. What about the place? What is that that is on the edge of
The CSF analysis results. Yes, the patient had bacterial meningitis. I want us to talk about directed communication. I heard Professor Maka say, can I have 5% dextrose? And I think in such an emergency, with a team, a big team, it is important to mention the person you're directing the instruction to. So I'm curious to know what was going on with that.
I didn't know his name. Well, you knew I was talking to you. You knew I was talking to you. I looked at him and asked him. I'm sorry. Let me tell you your name now. Nicholas. Okay, I didn't know his name. But yeah, I looked at him. We made eye contact and I said, give me. So
He knew he was the person.
Yeah, so he knew I was talking with him.
was close.
Sorry about that.
Thank you. Yeah, it is important to direct your communication to a particular person when the team is big and there's an emergency, and there are many ways in which you can direct your communication to someone. You may not know that team. In most cases, you actually don't know that team with whom you're working, but just like Professor Maka did, if you look at someone in the eyes and they know you're talking to them, that is good enough. But most importantly, you need to direct your instructions to a particular person. If there are name tags, you could read the name of the person you're instructing. Yeah, you could also read the points or look straight to that person so that they know they are the ones you're talking to.
Maybe I have something to do. When they are finished the procedure, the patient didn't respond.
Okay.
And they were proceeding.
Okay.
Because, and me what I was observing, the period was too small for what we were doing with the patient. But again, you said it is paper. Now my question is, has that patient been helped? Yes, because it's incomplete.
Oh.
Yeah, that's what I was looking at.
You're curious to know whether
yes,
the patient was
helped. Because no response, you've given what you think is supposed to be done. You go on with more other procedures, you take more samples. That's what I wanted.
Okay, what did the others, what did the others think? Do you think the patient was helped?
I think the period was short, but we managed to help. First of all, we did the lab investigations. We gave the first dose of chloroquine, and also because of the fever, we gave that. So we don't, in that short period, we don't expect our patient to respond.
Yes, I agree.
Yes.
Most of the things that were required to be done were done. However, the response may not be immediate.
That's true.
So, I want us to talk about communication skills. I noted that the senior house officer had written medication and for the patient, and one of them was high-viscous traction, which the attendant said the patient was allergic to, and the team changed the medication to chloroquine. And I think it is important to communicate to the person that have prescribed and agree with them before changing their medication. So I wonder what you are thinking.
We forgot.
The plan.
You need to read the SHO's plan.
No, she did.
I did.
But we kind of, for me, I think intention forgot actually. But I know ideally we should call the SHO, discuss with him, and then so that we're together on the same page. Because if we don't do that, we'll just change prescriptions. That means ultimately we'll be on a war path with the SHO, and it will not go well for the patient. So usually we need to be on the same page. If we have different opinions, we should speak and talk with one another. So we should have called him to say this is the problem and this is what we plan to do.
But in an emergency, when we're trying to save the life of the patient at that time, although the attendant or the patient relation, like we will call or the wife, was a bit anxious and worried, and I'm wondering if we know what is right to give, should it be at that point, or is when you have done that you can call to inform the person? So in my opinion, I would have thought that we're trying to save the life of this patient now. If he's allergic to the drug that has been prescribed, if they change it, it's after what you've done that you can call, since it's an emergency call. But I don't know.
But, well, sorry.
Yes, okay.
I think, as you said, that will be a good point, a good step to take. But sometimes, too, there may be a reason why the SHO may have written that despite the fact that the person had an allergy. So he may give you some reasons, or maybe he will tell you, well, he could accept that yes, he didn't know about the allergy, or it could be that that history was not properly taken, that he took another history and found out that it wasn't, that it was another drug that sounded like it or something. So you still need to talk about it.
Yes, so just like Professor Maka said, you need to discuss with the SHO before you change the medication for the reasons she has pointed out. I would think before you give another medication, unless there is a barrier in communication, maybe you cannot reach the SHO, by all means you have failed to communicate with them and you have to save the life of a patient. But this HO had just left the ward and was still nearby, so it would have been better to first discuss with him and agree on the medication. Otherwise, you give chloramphenicol, you will come back for the evening round and give ceftriaxone and yes. So I want us to talk about that challenge that you have identified that happened. Professor Maka said she forgot to call the SHO, and that can also happen in the real situation. So in that case, what do you think would help in such a situation where you're working as a team and maybe you forget to do some things or to...
Okay, in that case, I think since we forgot and we did not even, among us, we did not even realize that we were making a mistake, maybe we would, okay, we first document what we have given at the real time, and then inform the SHO that the patient conditions was alarming, and then also the attendant was restless, so we needed to give something, and since we found that the patient is allergic to surfactant, which we have not confirmed, we decided to give chloramphenicol. So then we asked his view about it.
Yes, I agree. Any other strategies that you think could work? Yes.
I'm sorry, but I'm trying to catch up. For me, I think in practice, antibiotics are not an emergency. So, however, there are other emergency things that would have acted on. Since it was a big team, I think as other people were doing something, another person would be doing the communication. Because when we are working in a team, it's important for each and every person to have a role. Otherwise, if one person is making decisions and doing well, at the end of the day, that's when we forget. I think having a plan and knowing who does what was very important. Because the person who is responsible for communication would be communicating as another person is going ahead to do the emergency kind of intervention.
Okay, thank you for that opinion. So the challenge that I'm talking about now is forgetting to call the SHO. That's what happened. So
yeah, I think if those roles are like clear, the issue of forgetting doesn't come But the issue of forgetting comes when you are doing very many things the same person. Because if one person was responsible for communication, for example, then I think you would rarely forget. But if you are the same person doing all the things, you normally forget. And I think what kills most of our patients during emergencies are those small things that we forget and we make medical errors.
So, but in this case, other things, immediate things to do was in place already. The forgetting is because of the drugs law to give, but there was a communication on which one to actually, the best choice to use, and we even had to, somebody was actually checking to see other medications that could be used. So at least there was a communication and agreement on what to do. I will still go with the fact that we should document it properly so that even if the senior health officer comes at any point, I'm sure he will not just jump into doing it. He will have to read the notes. So importantly is to document and then give your reasons, for changing the drug or using it. And if possible, if you remember immediately, you also call to inform the the senior health officer that this is what has been done, so that he's not taking unawares when he comes. So, in my opinion, I think that is what.
So when you remember, if we as we forgot to do it, when we finally remember that we haven't done it, we'll call the SHO, tell him what happens, and apologize. We go ahead of time to say we should have called you, but because of how things were going on, we totally forgot. So please, we apologize, and we'll try to make sure it doesn't happen again next time. Nicely.
Okay. In addition to what they have said, we first even converge in one place, and we ask, should we give, since the patient has been allergic to his infection, should we give benzene penicillin? The team said no, just wait a bit. So, Nicholas,
did we say no?
Yes, you actually say no.
No, I said I'm not sure. I'm not sure of the dose, but you told us the dose. But I asked him to now check the book for the dosing. Then he now saw other drugs, so that's why we didn't.
Yeah, so then we came into agreement because of that. So all of us agree. And
proper documentation.
Okay, thank you. So I want us to talk about the role of the team leader. I noticed that the team leader, I'm not very sure who the team leader was. Who was the team leader?
She was around.
Great. But I noticed that you are all involved in patient management, and I think a team leader is supposed to stay hands-off so as to keep watch the whole situation of have a bigger picture of whatever is going on. So I wonder what was going on in your mind, please.
Actually, I stood to watch what they were doing, and when the report came,
the tension was high.
She had not given us the history from the patient, so I had to read. As a team leader, I had to read. I called my members together. Then I asked them, what are we going to do? So then she said, let's first do the lumbar puncture. I said yes, but then I said, let us first think of our safety. Let's put on glove. So all of us were. So when I put on glove, she said, no, that for you are protected. Please, can you do the lumbar puncture? So I did the lumbar puncture.
She became the devil in that.
We changed the role.
Yeah, teamwork.
It
was a teamwork.
It was a teamwork, but because she was also working. She was also doing other things. Yes.
She was just swift in doing so, because at a point is
that one first, because when the quality of care for this hypothermic baby improves, you are addressing the other gap of neonatal care. But this one here, I don't know. Is it an
can't tell.
I think,
Thank you.
Yeah, thank you so much, Dr. Jerry. I think for us as a group, we looked at, so attitude is broad if you talk about attitude, but this is about attitude, poor attitude by those that didn't attend the training. I think that's really, so if you didn't attend the training, that's where the problem comes, and I think that's the simplicity of the issue. So attitude is a big issue we acknowledge, but usually across the board is that whenever trainings happen and you go back, those that didn't attend always have a poor attitude, and that's what we want to address as a group. Yes, so that's really the big problem. Yes.
So we selected something that will cut across, which should be addressed by the administrators, policymakers, caregivers, and everything. So it's an all-encompassing issue picked instead of going into clinical things, helping babies, this and that. Because at the end of the day, the worker don't work. All those helping babies, breed and other policies, I think it will not work at all. So trying to address human resource in terms of function.
Thank you, Prof. Simon.
That is and then come up with the next plan or how to proceed with the patient. So in such a case where you need to chip in, maybe there's a procedure that you are best at as a team leader, then you first delegate another person as a team leader, and then you get in and do whatever you're going to do. Much as you switched quietly, but it should have been, you should have said it out. Amaka can take up the position of the team lead as I do this. So let's talk about thinking aloud.
Maybe you have for this one. Let's see one thing which is coming out. You want to mention the team leader, so I saw something also as an observation. Wouldn't have been necessary also look at what we're supposed to do so fast, because it will help us. We're going to take something, you list them, they have a this. Then you move systematically under the patient. The other one will be better.
Yes, it's what the rest thing?
To me, I think it comes.
I think
you don't even brush it.
Like a team leader.
Yes.
I feel each one's opinion is important.
It is important. Okay.
So in this case, if we need to, each step we need to ask, what are we going to do? So then others will shift and say, do this. Because I asked, what are we going to do? Then we continue again, say, okay, let's do lumbar puncture, let's do this. Let's see how to be with the access attendant. So at that point we did, but we were also lacking knowledge. So it was not flowing for this case.
Then maybe before maybe to cover that also. In the scenario, because it was a scenario, when the center working. Couldn't it have been better also for you as a facilitator to give us the time we are going to take? Also, it can help you to plan for your time when you're doing that. So do you think that was eliminated?
Okay, as a facilitator, yes. I didn't give you time.
Yes.
Because handling an emergency, when you have an emergency, you don't say how much time do I have to lose this patient or to what you do is what you're
supposed to be done.
Yes.
But I'm just saying,
you don't know how much time you have with this patient.
Yes, you did no time at all.
Yeah, so for me, I wanted to know what you can do in that time, in whatever time that you have. Yeah, I can predict and know that maybe you are going to proceed like this.
Okay.
But within the time that you had, then there are things that you had to have done.
Yes.
Yeah. And about listing down what to do. Of course, the team leader doesn't have to always know it all. He or she might be the most skilled person, most experienced person, and know everything that is supposed to be done, but doesn't necessarily have to be that. However, you could converge after doing the first emergency things. You could converge and agree. We have done this, and the team lead is the one supposed to guide it, call for the attention of the team. She or he should have been noting down what has been done, and then give you an update of what you have done so far, and then you agree as a team on what to do next for the patient. Yeah, but it is important to have a checklist.
Yeah, that's what I'm saying. It's not about this is done.
Okay, so I wanted to talk about thinking aloud. I had Nicholas say that he had many ideas that didn't come up because of so many things that were going on at that time. And I think it is important to speak out whatever you think when you're working with a team, because that one thought might be the one to save the patient. Yeah, so I'm curious to know what was going on in your mind at that time.
Well, first, to me, it almost looked like an emergency to me. Yeah. So I expected us to, usually, for me in my area of specialty, if I should say, we do things somehow in a systematic manner, like you said. So you find an emergency. So the SHO had declared maybe that confused the scenario. But if it was, the ideas I had was to do the ABCD, because this was an unconscious patient. Check airway, they're okay, check the breathing. We had the breathing, we had the higher respiratory rate. So as you check the breathing, probably you check things like respiratory rate, check the saturations of oxygen, and then you go to see, check the pulse rate, which we checked, the strength and blood pressure. So as you manage, and then after that, you converge and then start thinking. Because I don't think the other things will kill the patient quickly, including giving the antibiotics and the rest. That is what I was thinking in my mind. So when we started, the fact that we had history taken already kind of reshuffled everything. So that's why I think now our management became a little random. And you could give antibiotics, you could do a lumbar puncture, you could do a CBC. Yeah, that's why I think you're also saying it wasn't systematic and organized. Yeah.
Thank you, Nicholas. So you see, you had a very important idea in your mind of the primary survey, ABCD, which is the ideal way to approach any emergency, because whatever is going to kill the patient is within that ABCD. So it is very important to speak out whatever comes in your mind when you're in a team. For example, you would have said team, or maybe team lead. I think we should first do a primary survey, and then we can proceed with the other assessments or investigations. And I think the team would have bought into your idea, because the primary survey is the first thing that you need to do in an emergency situation. The rest of the things would have come in after. So it is important to bring out whatever thought that comes in your mind. What kind of things might get in your way of implementing some of these ideas that we have talked about, like bringing out your thoughts? What kind of things in real practice, if you flash back in your workplaces, what kind of things might get in your way?
Yes, anybody?
Anybody?
Okay. Actually, because we're working as a team,
it's assumed that the team leader is probably the most senior in that group. So there's the issue of hierarchy and seniority in it. So, and if a junior person is the one taking the instruction, you'll be careful not to just jump at saying or airing your views immediately. So you want to wait until the right opportunity, or maybe when you are asked, or maybe when you converge and the team leader says, any opinion or what do we do? So there's an issue of hierarchy in it that can come in the way. The other thing is maybe based on our culture or where we come from. Medicine is apart from seniority thing. Hidden quietly is the issue of the gender differences too. Whether it's a male or female person giving the instructions, sometimes subtly it happens, whether who is giving me the instruction or who is taking the instruction from that. But apart from that, what is available for you to also be effectively utilized?
And the health vaccination talks, not a priority, yeah. So when women are coming for their ANC, perhaps they're not receiving sufficient education on the importance and the benefits of the vaccination. So knowing that after delivery, this is a really important benefit that their baby will be missing out on if they don't come, if they end up having a home delivery. And the policy is there's not sufficient vaccination outreaches to the community, and even though the service is free of charge for the vaccination, there's often a fee for the vaccination card to be signed, which can be its own barrier.
So this idea was borrowed from one of our colleagues from Nigeria. So if you hear some aspects which are not in context with other places, these apply to their community. Any comments from the team? Questions? Explanations? No? Okay. Questions? Yes, go ahead.
On the procedure, where when we have outreaches, it's places, yeah, but also there is when the vaccine that the baby should be getting at that particular time is actually not at the facility. So where is that?
Yes, that'd be great.
So, the way it works is that the immunization system in Nigeria is structured into two ways. So we have the routine immunization and we have the outreaches. So the routine immunization is provided in the facility. The outreaches are not done regularly. They are meant to mitigate poor uptake, and probably they are done sometimes every 3 months interval or sometimes 6 months interval. So the vaccines are available in the facility. But if you look at it in the context of a primary care setting, which is supposed to be the closest to the people, it's a setting where probably you have like 3 or 4 people at the max running the place. So they do not operate 24 hours. Sometimes some of them will operate from 8 to 2. So if there's any problem, they can call them from the community to come if they are available. For some facilities, there are 2 of them just running the place. So the vaccines are sometimes, most of the time, available in the facility. But when women deliver at home, it becomes a complex issue. Culture, there are sorts of cultural practices that even restrict or forbids a woman to go out immediately after delivery. Sometimes it's 40 days. So you just be there, they will be taking care of you, but the child is missing on other things. So but vaccines are available in the facility, And if they take the child there within the operating period, sometimes 8 to 2 or 8 to 4, they will be able to access the vaccine. I hope I answered.
Yes, you have. Thank you. But in the Ugandan setting, BCG, my sister delivered at the facility she delivered at. They told her, we are not going to give you BCG. So she was discharged home when the baby didn't get big. So then they schedule immunizations.
And you're going to design a process so that every baby who's born in the, I'm just giving an example. So break it down further so that then you can show that you made a change. Then you can go to the next one. Thank you. Somebody else had their hand up. Okay.
So that coaching, he told us that their coaching is very good and maintained well. And their vaccine supply is adequate, but if it was in the Ugandan aspect, you would consider that still either under policies where we don't have regular supply of the vaccines, something like that.
So you're resolving it in two different institutions, you're looking at two different whys. Yes. One institution is vaccine is not available on time. The other institution is the vaccine is available on time. Why is it not getting it? Yeah. So that's why locally doing your PSA is a great example of why you need to sit down locally with your team and design your PSA to solve your local issue. And you'll find a different solution than the people where the vaccine is not available. Sorry, go ahead. Two more comments.
Thank you so much. For me, I'm requesting for clarification. Why do you feel insecure under procedure? Why are you feeling insecure? Why is insecurity under procedure?
One of us or the team lead said, no, it's supposed to be I am and not IV. That would have been a medical error that probably would have cost the life of that patient. It is important that we should now be able to afterwards say, okay, in this situation, bring out the line of management in an emergency. This is how to administer this is how to, and we can put it we can just place it there for future, yes. For emergency cases, these are some of the emergencies that we're able to see. Emergency of this, and this is SOP. This is how to go about it quickly. For drugs, these are the drugs that are IM, IV, just quickly at the corner that we can look at it so that, because we've noticed that there was a possibility of an error occurring. So in order to mitigate against it, this is just to keep it for knowledge. It doesn't mean that you're less knowledgeable, but we want to avoid future mistakes. That's my own opinion. And again, we need to also study what are the drugs that are readily available for us as alternative to use that we can keep, so that we're not thinking of high-protein medications when we know we don't have them available. Well, the kudos to us that we're able to make reference to a book. In my own opinion, that's a book probably within the SOP that we have, or whatever that is there. We should encourage that we should always make reference to it. It doesn't make you less of a doctor or less of a health professional to make reference to those things. But simple things should be put very vividly where people can see, not to make mistakes.
Thank you very much, Jessica.
For example, I think what we usually do in some emergencies that actually happen in cases like in the emergency room where you might not have such protocols. The person who gives the instruction, give this patient this drug. The person has been given the instruction needs to re-echo, to have a closed loop communication. You have told me to give diclofenac IM, that is how the team can confirm what you're giving and you're giving it the right way. But if you just keep quiet and give, they just see the adverse events, they don't know what exactly you gave. Yes, you heard what you were told, but because you're panicking, probably you drew the wrong graph, probably you've given it the wrong route. So re-echoing and having that close group communication helps to solve that issue.
Thank you, Aspa. You brought up actually 2 points, the close group communication, but also the clear communication. So I don't remember what they had communicated to you. What was the instruction about diclofenac?
Was it give diclofenac?
Yes.
I think it was give diclofenac.
Yes, it was not very clear.
It was not clear. Yeah, so
me personally, I'm used to giving IV drugs. Almost all my drugs are IV drugs.
yeah, so the instructions should be very clear. Give IM diclofenac 75 milligrams. And then the person receiving the instruction should also close the echo and say, you said I should give diclofenac IM 75 milligrams, and then get the response from the one giving the instruction. All right, thank you very much. We have discussed a number of things. We have discussed about communication, directed communication, clear communication, closed group communication, thinking aloud. We have also talked about the role of the team leader. We have talked about, yes, I think that's what we talked about. And I would like to hear from each of you quickly what you have picked from this discussion and how you're going to apply it in practice. Beginning with Grace.
Thank you so much. One thing I learned is that before we start, each person should have a role. And if there is any way that you want to change the role, then you should communicate. And you do a peaceful transition. Then thinking loud, come out and I think this is one area that I have a problem personally. If I can't even say that. I will just act without even, so I don't omit, but then I act and sometimes cause kind of like disorganization, I can say. The other one is doing this, then for me I will also do this, and, you know. So thinking loud is very critical for harmony. That's an appreciate.
Thank you, Grace. Sharon?
Before administering, giving out the drug, you need to first look at what you're intending to give to the patients.
Thank you, Sharon.
Michael.
Michael, sorry.
It's fine. Mine is when you work as a team, you need to identify each one's strength so that you know what forward when you're doing a task. That's what I mean.
Thank you. Nicholas?
Well, I can just first begin with supplementing on this. I think for us, when we're forming the team, we're not comprehensive enough. We're just saying, okay, so and so will do this, so and so will do this. I think we should have taken, because we even used a short time than you gave us, we should have taken more time. We'll be like, okay, in case of this, what are you good at? Please tell us exactly. So that when we go there, just in case we had given out roles, and then the scenario we have requires different things, we can reorganize ourselves quickly. Yeah. And then the closed loop communication also comes in handy. That is what I'll refresh my mind on today.
Thank you. Aspa?
I've learned, okay, I already know about it, but I'll refresh myself about the neutralization and to allow people to share their ideas. It's very important because someone junior can have a really good idea, but then they're not the team lead and probably they're even having the lowest hierarchy of the group. So they should be able to communicate and share their ideas because the actual goal is mainly to solve the issue.
Thank you very much. Yes, sister.
Okay, so for me, importantly is the communication, direct communication, and then refreshing on the closed loop communication too, and utilizing the environment and documentation. It is important to document things and admitting when you have made an error or when you don't understand things. There's always room enough to learn new things. So these are some of the things that I think.
Thank you very much. Yes. Yes, thank you very much. Today, what I've learned, first thing is that the team lead, as I was reading, I know some kind of. Then the second thing is that you first have to know the strength of your members, whom you are going to work with, and which did not happen, and maybe people are going to be happy up to now. I think we did not identify. We thought we were given a shorter time, but I think he has given us a lot of time. So I've learned that all the team members, we all have strength, and each one can choose to do it perform the duties which are even speak differently. And then when during the execution, we always need to convert and also to think of the silent who don't want to talk, maybe as team, which can give us what happened. Thank you very much.
Can I do something which I could one procedure to go forward, which is very important. You shouldn't leave it out. Because if you have a procedure, then the other thing is having a checklist as possible. Checklist because maybe it's a good ABC. Checklist will not be perfect. Because I do say that. Because it guides you well and you work better.
Thank you, Michael. Thank you all for your time. We have come to the end of this session. We are going to go and have our break tea, and then we shall converge here after break. Thank you.
Thank you very much.
Thank
you.
you.
Thank you for moderation.
Hi, my name is Nawetememe Bosebaduka. I'm a fourth-year medical student. I have been in simulation, I think, for 2 years now. It has been a wonderful experience because we get to have these scenarios where we just use mannequins instead of real-life patients. We can make errors and learn from the errors that we make. It's just amazing. These different diseases and different things that we might not have seen on watch. It's really, really, really incredible. In simulation, there are various things that we can learn, which include teamwork, working as a team, being a team lead. Ideally, in normal situations before I think I came to simulation, I wouldn't be in a position to be a team leader when leading a case or just playing along as a team member. What are my roles? What am I supposed to do? But with the introduction of simulation, that has really, really helped a lot. I have gained more confidence, I've gained more courage, learning from these scenarios that I can go back and just do these things on live patients, and I'm like, yes, I actually did this. Yeah, it's really an amazing experience. I'll be at the Simulation Symposium. If you want to learn more, you should come on the 16th of this month.
My name is Makanga Silva Evans. I'm a fourth-year medical student at Mbara University of Science and Technology. I've been exposed to simulation training for the past 2 years during my clinical years. And with this training, we're really exposed to real-life scenarios that we meet on ward and maybe elsewhere. What this helps us is that it augments the training we receive in class and on wards, such that in a way that when we actually meet real-life patients, we are ready. Personally, it has helped me. I am more confident and more courageous when I'm approaching real-life scenarios. And because of that, I encourage everyone, and we have been talking to the university administration, to expose this same training to other people of other courses or maybe earlier years who may benefit from it. If you want to know more about simulation training, come for the Sim for Life Symposium on 16th of this month. I will be there too.
My name is Dr. Albert Muhumza, and I work here at the Simulation Center in Bara University, and I work with a vibrant team to grow the simulation method in Uganda, Tanzania, and Nigeria. And what we're doing in Bara University is that we're extending this methodology to the postgraduates so that we can address the limited number of people that are trained in this method, and also to be able to have a continuity of this method being used even outside the simulation center, like on the wards and in the other learning places. And what we are having with the other universities is really to introduce simulation to their faculty by training them and also enabling them to be able to train their own students. All these people from Nigeria, Tanzania, Uganda, from all these institutions we've been collaborating with will be at the Simulation Symposium on 16th June. You can't afford to miss.
I'm called Tebulwa Joani Taberita. I work at the Simulation Center, also known as the Sim for Life. And at the Sim for Life, we look at many aspects and we have objectives that we target. And one of the objectives looks at gender and equity. In our communities, males are known to be doctors and the females are known to be nurses. But you will all believe with me that from my own experience, this is not true, because we have seen from our hospitals where we have female doctors who are equally good as male doctors. And also the other aspect of gender, we look at interprofessional collaboration, where we see how the nurses and the doctors, how they work or relate during their working hours. So we look at how we improve on how best the nurses and the doctors can work together. And also another aspect of gender, we look at hierarchy, where we know that in our day-to-day practice, the junior staffs, it may be hard for them to pass on their concerns to the seniors. But with this objective, we came up with an advocacy inquiry strategy that we taught to our students to help them improve on the way of how to communicate to their seniors without sounding judgmental or criticizing. More about this, you can join us at the Sim for Life Symposium, which will take place on the 16th of June this year from Igongo Culture Center. Thank you so much.
The Simulation for Life program is a partnership of academic and implementing partners that are committed to introducing and institutionalizing medical simulation methodologies in Africa. We work in collaboration with like-minded people who believe in skills acquisition, skills retention, and reflective learning to drive change in healthcare. We are headquartered at Mbarara University of Science and Technology. And from here, we have worked with several partners in East and West Africa. Currently, we work very closely with Lira University in Uganda, Busitema University in Uganda, the Catholic University of Health and Allied Sciences in Tanzania, and the Federal University of Jos in Nigeria. In Uganda also, we work closely with Moon University. And this work has all been towards introducing and institutionalizing medical simulation. The other part of our work is in capacity development with different multinational organizations for skills retention among in-service health workers. And with this, we have worked collaboratively to do capacity development with many organizations, including UNICEF, Save the Children, Doctors with Africa, and the Clinton Health Access Initiative, to mention but a few. For this medical simulation symposium, we welcome you all to Mbarara to be able to meet all our partners and also know the work that they have been doing in the medical simulation space. See you there.
My name is Logaju Charles, and I'm a fourth-year medical student at Mbara University of Science and Technology. I want to tell you something about a new conversation technique called Advocacy Inquiry. It is something that is built up and tailored to fit students' learning process. And it is something that has helped me speak better in difficult situations and across hierarchy. At Sim4Life, we are able to look at hands-on practice to save lives. And this is a program that so many students out there would benefit from if given a chance. However, I'm able to benefit sufficiently from this just right here under courtesy of Sim4Life. Click the link below to join us online for our Sim4Life Symposium on 16th June 2023. Thank you.
I'm Brutus Seli. I'm doing Bachelor Nursing completion. I'm now in second year. I'm very grateful to be in Simulation Lab at this time to give you this feeling where it's so interesting. Actually, I feel that really I'm doing now a degree in nursing because there's now a great difference between what I did in a diploma and as of now. When I came to have the first interaction in Simulation Lab, it was so wow. The skills we learn from here, they are of much importance to guide us when you handle the real cases in the hospitals. Therefore, I'm very happy, and as a class representative for BNC2, really my class is happy. I need to really send their thanks and gratitude to the team of simulation. So we urge that let this practice continue so that all of us learn hands-on, know the technical aspects, how to handle this kind of cases.
My name is Umuhire Joanna. I am a nursing student at Mbara University of Science and Technology. I'm in my final year. SIM has been of a very great benefit in my time as a nursing student because it initiated my experience of clinical area. When I was still in first year, second year, I didn't know what to expect. But the first time I came to simulation, it boosted up my confidence because I was able to see things that are relatable to the clinical area. I was able to see instruments I feared touching, even something simple as a syringe. I was able to touch the mannequins. And the more I came for sim sessions, I got more confident, and I was always encouraged to go toward. Some of the most important things that we learn from simulation is that we learn in a very calm environment. We are less anxious, and there is respect for every student in their different courses. As a nursing student, I've enjoyed working with other students, the medical students, to manage patients, and we've appreciated the working together. SIM is very important because we are allowed to make mistakes as we learn before we go to the ward sessions. Some of the things that we've been doing in SIM sessions, we get to face different scenarios, different patients, different situations, and we're able to learn how to handle them. There's a lot we can't learn in class. There is a lot that may be hard for us to learn on ward, but with simulation, we learn a lot. So for the time I've been here, I really appreciate simulation, appreciate what has been done here, and I would encourage most students to always pick it up and to learn more that is done in simulation, which is a lot. I encourage you to come for the Sim for Life Symposium on 16th of this month at Igongo. See you there.
My name is Shifa Nankunda. I work with Sim for Life as a coordinator for community activities. Part of the work that Sim for Life does is supporting healthcare providers through maternal and newborn programs. We do this work to improve maternal and newborn health through our training programs, and not only training programs, but we also work with technology. Some of the technologies that we work with have included prisms and the air device. And with all this, we've tested them with the healthcare providers, and we will be sharing some of the results from this testing. We do not only work with Southwestern Uganda, but we work with several health workers across the country. And from this work, we have learned several lessons, and we have also had several experiences. I'll be at the Sim for Life Symposium on the 16th of June 2023 to share some of these experiences, lessons learned, and the results from the implementation and the work that we've been doing to improve maternal and newborn health. See you there.
Hi, my name is Nawetememe Bosebaduka. I'm a fourth-year medical student. I have been in simulation, I think, for 2 years now. It has been a wonderful experience because we get to have these scenarios where we just use mannequins instead of real-life patients. We can make errors and learn from the errors that we make. It's just amazing. It's what we get to administer drugs. We get to know about these different diseases and different things that we might not have seen on watch. It's really, really, really incredible. In simulation, there are various things that we can learn, which include teamwork, working as a team, being a team lead. Ideally, in normal situations before I think I came to simulation, I wouldn't be in a position to be a team leader when leading a case or just playing along as a team member. What are my roles? What am I supposed to do? But with the introduction of simulation, that has really, really helped a lot. I have gained more confidence, I've gained more courage, learning from these scenarios that I can go back and just do these things on live patients, and I'm like, yes, I actually did this. Yeah, it's really an amazing experience. I'll be at the Simulation Symposium. If you want to learn more, you should come on the 16th of this month.
My name is Makanga Silva Evans. I'm a fourth-year medical student at Mbara University of Science and Technology. I've been exposed to simulation training for the past 2 years during my clinical years. And with this training, we're really exposed to real-life scenarios that we meet on ward and maybe elsewhere. What this helps us is that it augments the training we receive in class and on wards, such that in a way that when we actually meet real-life patients, we are ready. Personally, it has helped me. I am more confident and more courageous when I'm approaching real-life scenarios. And because of that, I encourage everyone, and we have been talking to the university administration to expose this same training to other people of other courses or maybe earlier years who may benefit from it. If you want to know more about simulation training, come for the Sim for Life Symposium on 16th of this month. I will be there too.
My name is Dr. Albert Muhumza, and I work here at the Simulation Center in Bara University, and I work with a vibrant team to grow the simulation method in Uganda, Tanzania, and Nigeria. And what we're doing in Bara University is that we're extending this methodology to the postgraduates so that we can address the limited number of people that are trained in this method, and also to be able to have a continuity of this method being used even outside the simulation center, like on the wards and in the other learning places. And what we are having with the other universities is really to introduce simulation to their faculty by training them and also enabling them to be able to train their own students. All these people from Nigeria, Tanzania, Uganda, from all these institutions we've been collaborating with will be at the Simulation Symposium on 16th June. You can't afford to miss.
I'm called Tebulwa Joani Taberita. I work at the Simulation Center, also known as the Sim for Life. And at the Sim for Life, we look at many aspects and we have objectives that we target. And one of the objectives looks at gender and equity. In our communities, males are known to be doctors and the females are known to be nurses. But you will all believe with me that from my own experience, this is not true, because we have seen from our hospitals where we have female doctors who are equally good as male doctors. And also the other aspect of gender, we look at interprofessional collaboration, where we see how the nurses and the doctors, how they work or relate during their working hours. So we look at we improve on how best the nurses and the doctors can work together. And also another aspect of gender, we look at hierarchy, where we know that in our day-to-day practice, the junior staffs, it may be hard for them to pass on their concerns to the seniors, but with this objective, we came up with an advocacy inquiry strategy that we taught to our students to help them improve on the way of how to communicate to their seniors without sounding judgmental or criticizing. More about this, you can join us at the Sim for Life Symposium, which will take place on the 16th of June this year from Igongo Culture Center. Thank you so much.